I know that Bert has contributed more to the field of GI and to our own hospital than anyone else who's come before him. And this is probably, although you call this a medley, of over, was it 250 papers and abstracts? I don't know how you're going to fit that into the next 50 minutes, but we'll find a way. So it gives me great pleasure to introduce Bert, and I can't tell you how excited I am to hear about his journey, the past 60 years, and maybe the next 60 years. So, Bert.
Thank you, Dave, and good morning to all of my friends and colleagues and students and my co-workers over the years. I can't make it brief. There's no way I can do that, because the lesson that I have to share with you today is that in order to see where we're going, we have to look back and see where we were then, a long time ago. I took my fellowship at the Beth Israel Hospital in Boston, where I was the first fellow in gastroenterology. And the history of ulcerative colitis was my assignment. So I spent just about every night in the catacombs of the hospital looking at slides where the records were. And the end result was published. Judy, I need you.
To advance the slide? Okay, so just use the... there you go, just your arrows here.
Thank you both. The end result was my first major publication after a few case reports on the course of ulcerative colitis with 20 years experience, which I did with my mentor, who was Dr. Benjamin Banks, and Louis Zetzel. It was Dr. Zetzel who really brought me into gastroenterology when he was my attendant at the Boston Veterans Administration Hospital. And what came of this study was a review of 245 patients that were seen between 1931 and 1950. And these were the results. Antibiotics and azolfidine, which was the only drug we had at the time, were only slightly more effective than supportive measures. 34% required surgery, and we learned quickly that ileostomy was not enough. Patients with segmental or right-sided colitis had worse courses than those with ulcerative colitis. Carcinoma occurred in 3.7% of 87 pregnancies. The best prognosis was when the colitis was in remission. Lessons that we were able to prove later on. The final story at the end of the day was that 20% were still well, 20% had mild disease, 20% were still seriously ill, 17% were well after surgery, but 20% had died of ulcerative colitis. My next big study was at Mount Sinai when I returned as a medical resident, and Dr. Crone came to me and said, I understand you have an interest in inflammatory bowel disease. We're getting our patients with ileitis, we're still called regional ileitis, together to see the influence of pregnancy. And the outcome of that was essentially that the people who went into pregnancy in remission did well, The people who had active disease did not do well. The next study was also at Mount Sinai, where I shared my first office with a very busy pediatrician, Dr. Donald Gribbets. And he had children being examined in one room, and right next door I would be examining adults. But in the course of that, he referred to me many patients, many children with bowel symptoms. So later on, I was told I was the first pediatric gastroenterologist at Mount Sinai. But we took all the patients, we now in the steroid era, but we reviewed all the patients pre-steroid era to compare those in the steroid era. And we followed 84 children with ulcerative colitis. Again, sulfonamides and antibiotics had very little influence. 85% developed complications, including carcinoma in 10% of the children, strictures, invalidism, intractability. Of 84 children, 1/3 died. 1/3 had ileostomy, and 1/3 were managed without surgical intervention. Only 15% remained clinically well for prolonged periods. Then in the steroid era, for comparison, the number of complications in the steroid-treated patients was reduced. The number of patients treated surgically with ileostomy and colectomy had increased. But the surgery was less urgent, and more elective procedures were performed. The number of operative stages was reduced, and the surgical mortality went way down. After 6 years of disease, 30% had ileostomies, but 89% were alive, and 40% were clinically well without definitive surgery. So we concluded that the response to steroids helps to determine which children with ulcerative colitis would profit by colectomy, and permitting the surgery to be performed early enough to avoid irreversible complications. This was progress. The next major paper was when Dr. Richard Marshak, the great radiologist, the great GI radiologist, came to me and he said, "Bert, I know of your interest in IBD. I'm collecting my cases of toxic megacolon and to see what the outcome is." And indeed, I worked on 19 episodes of toxic megacolon in 16 patients. Toxic megacolon was complicated by perforation in 4, 3 deaths, although steroids could affect a dramatic improvement in some. In others, if it was too late already, it had a detrimental influence. 9 patients required emergency surgical intervention, including 3 who were treated by cecostomy. Cecostomy then was a new procedure. It was the innovation of Dr. Sam Klein, who was a wonderful surgeon at Mount Sinai. And indeed, with a cecostomy, the colon was decompressed and permitting time for the patient to be treated medically. I then focused on what was still called granulomatous colitis in children. It wasn't yet called Crohn's disease because we were at Crohn's Hospital, and this was not accepted terminology. It was elsewhere in the world, in Europe, when gastroenterologists said, here, what are we using that long word for when we can just call it Crohn's disease? He's the one who introduced it. Wasn't completely true. It was introduced by Crohn, Ginsburg, and Oppenheimer, and they felt differently about it. They didn't agree it should be called Crohn's disease. But the children with granulomatous colitis, 25, onset before 16, the diagnosis supported histologically and gross pathology. These cases were predominantly right-sided, and involvement of the terminal ileum in 19. High incidence of fistulae, strictures, obstruction, nephrolithiasis. The outcome of surgery was discouraging in that 17 required 74 operations, including 45 major procedures. The disease extended to the rectum in 9 after the surgery, and in 8 there was proximal extension. At follow-up, 17 years, 4 patients had died. 3 of 8 medically treated patients well for 5 years. 9 required ileostomy. 2 died. Prognosis was worse when the TI was originally involved. Very sad picture, both of ulcerative colitis and of granulomatous colitis. This led to our study on growth retardation course, late results and pathological nature of IBD of the colon, initially sparing the rectum. We thought that maybe when the rectum was spared, more likely that was Crohn's disease, but nobody was sure yet. In 94 patients, and this was published in Guts in the late 1960s, 94 patients, high incidence of fistulas, skip areas, perirectal separation, ulceration and strictures. Bloody diarrhea, not common. But if they're bleeding, massive hemorrhage was more common. There was more arthritis, erythema nodosum, uveitis, kidney complications. Surgery was required in 72%, ileocolostomy with or without resection in 2/3, and half of these later required ileostomies. Extension to the rectum in 15% without surgery, and 54% following resection. Proximal extension in 40%. The lesson was that if the disease spared the rectum at the beginning and was clinically and radiologically ulcerative colitis, it proved to be pathologically Crohn's disease in 65%. With Arthur Lindner, who later went to NYU as Chief of Gastroenterology and Associate Dean, we did this long-term study on the influence of steroids on the course of ulcerative colitis, not limited to children. This concerned adults. And we saw that the course had been altered, the morbidity had been decreased, the incidence of surgery was not decreased, but more elective, less emergencies, and overall the mortality was markedly diminished. This was my first paper published in the New England Journal of Medicine, along with my colleague Dan Present and Marshak and Chief of Gastroenterology at Mount Sinai, Henry Janowitz. it had been reported from Boston, both from the Leahy Clinic and the Beth Israel, that if you did a colectomy and ileostomy for what was then considered Crohn's disease, you had no further recurrence of inflammatory bowel disease. This was not my experience. So we went back to the catacombs at Mount Sinai, pulled out all of our patients with Crohn's disease of the colon who came to surgery, and we found out that 40 to 45% had recurrences of Crohn's disease in the ileostomy if it was Crohn's disease to begin with. So this is well accepted now that surgery does not cure Crohn's disease. Then I move into the era of immunosuppressive therapy. This is a long, sometimes sad story. I remember exactly how it came about. We had a pediatric pavilion at Mount Sinai full of children with ulcerative colitis. And it was at the time when there was a great deal of literature on autoimmune disease. And everyone with autoimmune disease was gathered, including people with ulcerative colitis and Crohn's disease, all called autoimmune disease. But at the same time, researchers were working on treatment of autoimmune diseases, not specifically ulcerative colitis or Crohn's disease. Why not use an immunosuppressive drug? This was published in 1972. You will notice there are two successive papers by Korelitz and Wish. I want to divert for a moment and say a few things about Dr. Wish. He and I were appointed by Dr. Bruno to be chiefs of our service on the same day. I had come to Lenox Hill before him. We came as chiefs. We were appointed as chiefs. I think it was in 1977. Nat had already had experience with the drug 6-MP, which is a derivative of azathioprine, in treating childhood leukemias. So when I suggested that we use azathioprine, he said, look, I've got more experience with 6-MP, let's use that. And that's simply how it happened. We collected many patients with ulcerative colitis, treated them with 6-MP, and we had about 75% success. Then our attention turned to treating Crohn's disease, because we had nothing medically with which to treat Crohn's disease. And again, I divert from the end results to tell you how difficult it was to get the attention of the gastroenterology community, needless to say, of their approval. We submitted our research on treatment of Crohn's disease with 6-MP for presentation at the AGA. Unfortunately, your research paper, the abstract, which is enclosed, was not accepted for presentation. Okay, it was one of the first double-blind, crossover, controlled trials of 6-mercaptopurine versus the other drugs then available, prednisone, sulfasalazine, placebo. I don't think it could have been a better controlled trial. I wrote both to the head of the committee, who had the power to accept the paper for presentation. I'd be most appreciative if you would share with us the deliberations of your committee in regard to our abstract. I'm not asking that our paper now be placed on the program, but I want to know why so we can correct this and do better. Dr. Presence was much more aggressive than I was. The letter that he wrote to gas mineralogy was extremely provocative, but neither one had any influence. The paper was not accepted for presentation. However, this was my second paper in the New England Journal of Medicine. It was accepted for publication. In the May issue of 1980, it was published as the lead article, The Treatment of Crohn's Disease with 6-Mercaptopurine. Followed soon after by favorable effect of 6-MP on the fistulae of Crohn's disease. Even then, we made an effort to defend our results and compare it with the National Cooperative Crohn's Disease, which took place at 14 centers supported by the American Gastroenterological Association, and they came to the opposite conclusions, that azathioprine was ineffective in the treatment of Crohn's disease, and the best drug was prednisone. Well, we went on to counter those statements by showing the shortcomings of the National Cooperative Crohn's Disease Study, the exclusion of azathioprine without adequate trial, insufficient number of patients treated with azathioprine, early withdrawal of steroids in patients randomized to azathioprine. You can't cut off steroids and expect there not to be some relapse. The period of the trial was limited to 17 weeks. The adequacy of drug dose on the basis of weight. The arbitrary nature of the Crohn's Disease Activity Index, which was dependent too much on diarrhea, abdominal pain, and subjective rather than objective symptoms. What's happened to 6-MP since then? I'm really honored today to have my close colleague Norman Sohn here in the audience listening to this. Norman and I had so many patients together with inflammatory bowel disease. He's a master surgeon and a collaborator. Norman, stand up for a moment, will you? Because not many people here know you. One of the first publications to show the value of 6-mercaptopurine was in the surgery of anorectal Crohn's disease. The next step was pancreatitis. At that time, occurred in about 3% of the patients treated with 6-MP. And another study on the role of leukopenia in 6-MP induced remission of refractory Crohn's disease. These were the results in the pancreatitis study. We had 13 cases out of 400, 3%. The timing of the pancreatitis was such that it could not be attributed to sulfasalazine or steroids. Dosage of 6-MP varied. It could happen after one dose of 6-MP. Epigastric pain, back pain, fever, nausea, elevated serum amylase. In all cases, the 6-MP was stopped. The symptoms and signs returned to normal over a few days. Of 7 patients re-challenged with 6-MP, all developed recurrent pancreatitis, including 4 in less than 24 hours. We attempted desensitization with gradual increase by 1/8 of a tablet at a time. Didn't work. 6-MP could not be reinstituted once it had caused pancreatitis, which almost surely was an allergic reaction. Other studies on 6-MP, and you will notice that John Warman was the first author on cumulative experience with short and long-term toxicity to 6-MP. Mark Fleischer was a fellow at the time as well. I got an email from him yesterday. He heard about this lecture. He said, I can't fly up in time to get there. Then we looked at the optimum duration of treatment with 6-MP. This is when Peter Kim was a fellow and Yusuf Zlatanich was a fellow. We found low incidence of drug-related allergic reactions as time went on. Desensitization with 6-MP or azathioprine was often successful. Significant leukopenia with 6-MP was observed. In some cases, we did it on purpose to see if it would work better. Infectious complications, 14%, including shingles. We recognized diabetes as a complication. No significant difference in the incidence of neoplasms from our earlier studies. But we had already seen 3 cases of lymphoma and 2 leukemias, not greater in incidence than the overall IBD population, but we were watching it very carefully. Dr. Present and I published a history of immunosuppressive drugs on more than one occasion. More recently, we collaborated with Jim Lewis at the University of Pennsylvania and did a study on trying to determine the true risk of lymphoma in patients treated with immunosuppressants. And we show that there's a 1 in 4,000 risk of developing a lymphoma on patients with immunosuppressants. The incidence of neoplasms in the patients in who developed sustained leukopenia, we wanted to see if the leukopenia itself increased the risk of the carcinoma. And there was a trend toward a greater number of malignancies. So we knew that we had to be careful about the leukopenia. More recently, and I see Marlon Sachi is in the audience, when he was a fellow, we published this paper, is treatment with 6-MP for colitis associated with the development of colorectal cancer. And the conclusions were there's neither sufficient evidence to state that 6-MP is associated with increased colon cancer, nor that it has a chemopreventive effect. And as recently as last year, you will see that Prashant and David DiCaprio, who's not even yet a fellow, and my former fellow, Keith Sultan, were all authors on this paper on the risk of new or recurrent cancer with IBD who had previous cancer and were now exposed to immunosuppressive drugs. No increase in cancer. This was probably Dr. Present's last paper with me before he died. That 6-MP and azathioprine remain important contributors in managing Crohn's disease. And that's because there were two papers from Europe, one from France, one from Spain, say early use of immunosuppressives does not affect favorably the long-term prognosis. Again, we had to defend this because it just wasn't true. I need to share with you a separate area of investigation. When Dr. Summers, Sheldon Summers, came to Lenox Hill as our director of pathology, he was one of the first pathologists to describe Crohn's disease and ulcerative colitis with Shields Warren in Boston. So we became a team, and he had the idea of counting cells on biopsies. So it resulted in at least 3 publications on mucosal cell counts in ulcerative and granulomatous colitis, response to drug therapy in Crohn's disease, evaluation by rectal biopsy and mucosal cell counts. And what he showed, comparison of cell counts on sigmoidoscopically positive ulcerative granulomatous colitis showed more pycnotic epithelial cells in ulcerative colitis than Crohn's colitis. Comparisons of connective tissue cells in cases with normal sigmoidoscopy showed more mast cells, plasma cells, eosinophils, and neutrophils in ulcerative colitis, but in granulomatous colitis, more macrophages. The conclusion was that the combination of the gross appearance on sigmoidoscopy and the cell counts on rectal biopsies appeared to provide a very effective combination of diagnostic criteria. Of course, this never really went anywhere because the pathologist is an employee of the institution and doesn't have time to count cells. So it remained a research tool, but was never accepted for practical utilization. We've been interested in pregnancy in many papers. Is Peter here this morning? Hi, Peter. I really have to hand it to Peter Bianco. This was a publication in 1984 when he was a fellow, The Influence of Inflammatory Bowel Disease and Its Treatment on Pregnancy and Fetal Outcome. His data showed very clearly that it wasn't the drug that the patient was taking that led to adverse reactions during pregnancy, but was the disease activity. This recognition has been attributed to many different people, but Peter is the first one to have recognized it and published it accordingly. Out of 147 pregnancies of 124 women, they were divided into 2 groups. 46 ulcerative colitis and Crohn's who received drug treatment during pregnancy, and 101 who received no treatment during pregnancy. the frequency of fetal complications was higher than the general population in the treated patients, but not higher than in the patients with IBD who received no drug treatment. Active IBD was present in 43% of the treated patients whose pregnancies resulted in fetal complications. Patients receiving therapy during pregnancy are at greater risk of fetal complications, but disease activity is more likely to be responsible for this risk than drug treatment. Subsequently, when Ramona Rajapaksa was fellow and Yusuf participated in this as well, we reported the outcome of pregnancies when fathers were treated with 6-MP for IBD. And we showed that if the wife was impregnated by the husband who had IBD and was taking 6-MP within 3 months of inception, there was an increased risk of congenital anomalies. This wasn't too well received either. Subsequently, with Yusuf Zlatanich as the first author, and Ramona and Steve Rubin and Peter Kim participating as well, complications of pregnancy and child development after stopping treatment with 6-MP for IBD. No clear-cut conclusions there. Another aspect of research was when Jerry Way was here as head of endoscopy. We took my patients with Crohn's disease, either colitis or ileocolitis, and Jerry did gastroscopies on all of these patients with biopsies from the esophagus, stomach, and duodenum to determine whether there was any inflammatory manifestation of the Crohn's disease in those biopsies. And in 45 patients with Crohn's disease in whom gastroscopy was done, Dr. Summers did cell counts of 500 connective tissue cells of the duodenal mucosa, as well as histological examination. Histological lesions were found in 19 Crohn's disease patients. 11 were considered pathologically diagnostic, and all were found in the antrum or duodenum. In 11, the mucosa had been endoscopically normal, and even granulomas were present in 3 cases, all from normal appearing mucosa. So microscopic alterations of the antrum and duodenum, similar to findings in the normal appearing rectal mucosa, support the concept that Crohn's disease involves the entire alimentary canal, and that lesions are seen grossly only when the disease is most advanced. So this established Crohn's disease to be accepted as a more extensive disease process. Early on, we tried desensitization to sulfasalazine in people of whom there were many were allergic to the drug, and it was successful in 100% and particularly those patients with ulcerative colitis, went into remission coincident with desensitization to sulfasalazine. This is what prompted us to try the same thing with 6-MT at a later date. The subject of dysplasia, one of the early recognitions that dysplasia could occur in Crohn's disease as well as ulcerative colitis came from Lenox Hill. And our surgical colleague Mike Weinstein, Dr. Sohn's partner in practice, participated in this. And then we came to surveillance in the routine management of ulcerative colitis, the predictive value of low-grade dysplasia. This is when Audrey Woolrich was fellow. Is Audrey here now? No, okay. And what this showed was that we took biopsies and colonoscopy from 121 patients with ulcerative colitis over 7 years. Dysplasia or neoplasia was found in 27 or 22% after a mean of 16 years. It was all low-grade dysplasia. 7 had dysplasia on the next examination, and another 4 after multiple negative examination. So dysplasia preceded carcinoma in 18%, but carcinoma occurred in 6% independent of dysplasia. The average time from dysplasia to carcinoma was 6.3 years, and 3 out of 4 patients with negative second colonoscopies then had unremarkable examinations for another 2 to 5 years. So dysplasia was also found in 12 out of 13 colectomy specimens, including 3 from patients with cancer in whom no dysplasia had been found by biopsy. Low-grade dysplasia, we concluded, like high-grade dysplasia, is predictive of future carcinoma and warrants careful follow-up. A negative second examination is no basis for a sense of security or relaxation of vigilance. When Dr. Sohn and Dr. Weinstein were active, Alex Key was here as a surgical resident. She's now a colon and rectal surgeon at Mount Sinai. We did this study on carcinoma arising in anorectal fistulas. We found 8 cases in 7 patients with Crohn's disease, 4 squamous cells, 3 adenocarcinoma. Can be very difficult to diagnose. Examination may be limited by pain, stricture, induration, perianal disease. We resorted to diagnostic examination under anesthesia to increase the yield using both biopsies and curettage of fistula tracts. This was an entity that was first described here at Lenox Hill when Larry Cheston was a medical resident. The proctitis that follows fecal diversion in Crohn's disease, a distinct entity, no sign of it being Crohn's disease, and the interesting thing was if the patient was reanastomosed, the proctitis or diversion colitis went away. Narcotic dependence in IBD is very important. early on I saw many young women, particularly with Crohn's disease, who were addicted to narcotics. And this study with Marvin Kaplan, a psychiatrist here on the staff, from it we recognize that we have to recognize drug dependence in young women with Crohn's disease by interviewing family members, not just taking the history from the patient himself. And also we learned that having one physician assigned to prescribing any narcotics, because as with other groups of people who become addicted, patients with Crohn's disease went to many doctors to get prescriptions. The study on IV Solidor-Cortef versus hydrocortisone was done when Alex was a fellow, and Ron Chardy was a medical resident, and we found that they were pretty much the same, but that ACTH had a slight advantage. Is the Crohn's Activity Index outdated? Yes, it's outdated. I feel it's been outdated ever since its inception. The study that Joe Felder did on non-steroidal anti-inflammatory drugs was very important. There were 60 IBD patients treated with NSAIDs compared to 60 patients with irritable bowel syndrome, who were also NSAID users. And in the IBD population, 31% had a correlation between the use of NSAIDs and IBD activity. Conclusion, NSAIDs provoke disease activity in both ulcerative colitis and Crohn's disease and should be avoided in patients whenever possible. Very important is the role of anorectal skin tabs in Crohn's disease. This study was done when Jen Bonner was a fellow, and Jared Braunstein was a medical resident. And here's the variety of anal skin tabs that we saw. And our observations supported the diagnostic value of skin tags when they're discovered on physical examination, especially in young people with diarrhea, abdominal pain, and growth retardation. And this has led to our current study being performed by Elena and Kelly on the pediatric population and finding anorectal skin tags well in advance of other overt manifestations of Crohn's disease. Crohn's proctitis was reported from Lenox Hill. Jeff Aronoff was involved in this. It's a different phenotype of Crohn's disease. Histological healing favors lower risk of colon cancer and extensive ulcerative colitis. And you see one of the people who contributed to this study was Megan in her first tour in gastroenterology before she returned for her second tour. And I feel this is a very important observation that shows that not only gross mucosal abnormalities, but persistence of histological inflammation leads to the diagnosis of colon cancer. And as many of you know, I've always had an interest in the iliorectal and iliosigmoid fistula in Crohn's disease. I wrote a paper in the Mount Sinai Festschrift for Dr. Marshak when he died, reviewing what he had taught us about this. And we have a current accepted for publication on the progression of the fistula to sigmoid polyposis and then to sigmoid strictures as well. I've always had an interest in history aside from IBD. A Harvard medical student chronicles his fatal illness. This was about subacute bacterial endocarditis. Alfred Reinhardt described his own case right up to the day before he died. And where was it published? Eventually in the Journal of Mount Sinai Hospital, in one of their fish strips. The early history of gastroenterology at Lenox Hill. I don't know how many of you are aware, but do you ever see the relief at the entrance to Einhorn Auditorium with the three faces there? One of them was Ernst Boas, who many consider the father of gastroenterology in the world. He influenced many of the German doctors who came here. And of course, Max Einhorn was the first chief of gastroenterology, after whom the Einhorn Auditorium is named. But we published this, and I think it's really worth reading. Finally, the history of Crohn's disease, which I've always been interested in, and it included anecdotes about Burrell Crohn, Eli Moshkowitz, who describes thrombotic thrombocytopenia purpura. He was one of my first teachers. Dr. Summers on the left with the glasses, and Dr. Way, who you all know, Hitchings and Elion, who got the Nobel Prize for azathioprine. My picture with Dan present at one of the ileitis colitis meetings. Dr. Sacker, who became chief of gastroenterology at Mount Sinai. Dr. Aufsis on the right, who was resident in surgery when I was resident in medicine. And often we ran Mount Sinai Hospital and made all the decisions together late at night. And Lloyd Mayer, who unfortunately died prematurely very recently. Many of these people taught me, and despite their idiosyncrasies, they were all great men, and I'll always be very grateful to them. Thank you for your attention. I hope you enjoy it. If there are any questions, I'm glad to answer. Norman, thank you for coming. I appreciate it. It's really very nice. Yes, Eric.
I don't have a question. I just want, on behalf of, I think, most people here, thank you for what you've given us, done for us, and it's always appreciated. Thank you.
Thank you, Larry. Thank you very much. And I want to hand that appreciation on to Judy Schneider, my database technician, because without her, I could not have given this presentation. She really put it all together for me so well. That she could practically give the talk. I'm sure she could. And I want to thank my grandson, Theo, who wanted to video this, and let's see how it comes out.